Hello, welcome to this clinical education channel. I'm Boon Seng, and today I'll be talking about abdominal and thyroid examinations, specifically cater for undergraduate internal medicine rotations. And here are the learning outcomes of this mini lecture. Number one is to understand the sequential steps in performing abdominal and thyroid examinations, to describe the common clinical signs in abdominal and thyroid examinations. We will first start with the abdominal examinations. The purpose of this physical examination is to identify pathology of intra-abdominal structures such as liver, spleen, kidney, ascites, which is pathological, hollow viscous, uterus, and ovary. So the examinations of the abdomen, you should position the patients flat on an examination couch. The exposures is classically described as nipple to inguinal, and the older text would include the external genitalia as well. On inspection, you should look for jaundice, pallor, sallow appearances, bruises, bruising, scar, fistula, or any catheter. So after you have done your inspection screening, you would proceed with a periphery examinations of an abdominal system. From on hand, we should look for leukonychia, which is a white nail, koilonychia, which is a brittle nail, Bill's-line, which are the ridges on the nails, clubbing, Dupuytren's contracture, palmar erythema, and check for hepatic flap. On the forearm, you look for tattoo and needle injection mark. On the arm, we should look for spider nevi, which is a telangiectasia, the abdominal dilatations of the capillary. On the face, look for Cushingoid features, whether there's temporary wasting, parotic swelling from alcohol use, jaundice, conjunctiva pallor, telangiectasia, angular stomatitis and glossitis, which would hint at nutritional deficiency, hepatic fetor, and aphthous ulcers of inflammatory bowel disease. On the neck, check for cervical lymphadenopathy. Also look for the presence of spider nevi and count how many of them. And look for scars of central vein cannulations in patients with suspected end-stage renal disease. Then you will end the peripheral examinations with a lower limb to check for pedal edema. We would next focus on patient's abdomen. We will start by inspections. Look for cough impulse from the hernia orifices. Look for dilated veins of caput medusae from chronic liver disease with portal hypertension. Look for visible mass, scar from previous surgeries, such as a midline laparotomy, paramedian, lance incisions, subcostal, rooftop, J-shaped scar of a renal transplant, nephrectomy, Pfannenstiel's incisions, and look at the umbilicus for eversions, which would hint at ascites, and whether there's umbilical nodes that would suggest a metastatic malignancy, classically known as Sister Mary Joseph nodes. Next, you move on to palpations. Always ask about pain before you start, and look at patient's face when you are palpating. On superficial palpation, you should screen for a gross pathology. On deeper palpations, it is to identify the characteristic of the abnormality. You palpate for hepatomegaly and splenomegaly. Both liver and spleen move inferiorly with respirations, and you cannot get above them. And characteristically, the spleen has notch. You should time palpations with patient's respirations and measure any palpable mass for their size. And lastly, you should look for any enlarged kidney. On percussions, you should detect shifting downwards, which should hint at ascites. You should percuss also the throat space, which superiorly is limited by the sixth rib, laterally limited by anterior axillary line, and inferiorly by the costal margin. It is the left lower ribs where also the stomach lies, and downwards not necessarily always mean a splenomegaly if the patients had recent full stomach or taken any meals. So, percussion of throat space would hint at splenomegaly, but it is not always so. Lastly, on auscultations, you should listen for renal bruit and listen for bowel sound. You would conclude the examinations by examining the external genitalia, digital rectal examinations, examinations of the hernia orifices, and check the temperature chart. There are possible scenarios in the abdominal examinations that could come up in the exam. There would be isolated hepatomegaly, and the etiology could be liver or malignancy, isolated splenomegaly, usually of hematological causes, and hepatosplenomegaly if the patients have portal hypertension or chronic hemolysis, such as thalassemia or chronic malaria. There could be a unilateral or bilateral renal mass of adult polycystic kidney disease, and in the undergraduate setting, renal transplant is quite unlikely, and if you get a surgical abdomens, there will be stoma, sinus, and fistula. The next section would focus on the thyroid examinations. The purpose of this exam is to characterize any goiter, and you can find this case in surgical or medical rotations. And the second purpose of thyroid examinations is to assess patients' thyroid status. At the end of the examinations, students should be able to confidently tell the examiner whether the patient is euthyroid, hypothyroid, or thyrotoxic. On peripheral examinations, you should look at patients' appearances, note the body habitus, whether it is thin or patient has elevated BMI. Look at the patient's demeanor, whether they are fidgety or there's some slowness, and look at the skin, whether there's sweaty or there's a dry skin. On the upper limb, you should note the hand, whether it's warm or cold, and whether the patient is having irregular tachycardia of atrial fibrillations or bradycardia. Look at the nails for onycholysis or clubbing. Look at fine tremor and check for proximal myopathy. On the face, you would notice whether there's loss of lateral third of the eyebrow, which would be found in hypothyroid patients. Look at the eye for exophthalmos, lid retraction, and check for lid lag as well. Check for painful ophthalmoplegia or complex diplopia in patients with grave ophthalmopathy. On the lower limb, you should look for whether the patient is having a non-pitting edema or there's a pretibial myxedema in grave disease. Periphery examinations would inform a candidate of the patient's thyroid status, whether the patient is in euthyroid, thyrotoxic, or hypothyroid before candidate proceed with the examinations of the neck. Candidate should look specifically for scars of previous thyroidectomy. Be careful, this may be hidden in the skin crease, so you should look at the neck more closely. And goiter, which is a thyroid enlargement, will be felt as an anterior neck swelling. It should move with swallowing and did not move with tongue protrusion. You should check for the size, tenderness, nodularity, and retrosternal extensions for any goiter. You should palpate for cervical lymphadenopathy, which would hint at a malignant pathology. Lastly, you would auscultate with Bell for thyroid bury. You would conclude the thyroid examinations by measuring the blood pressure and performing a full cardiovascular examinations. Now, there's possible scenarios in exam for thyroid examinations. Patients may have multinodular goiter, which they are usually euthyroid. Occasionally, they may be having a toxic multinodular goiter. Grave disease is common, and the patients may have ophthalmopathy. And lastly, the patients may have Hashimoto thyroiditis, and you should look for associated autoimmune features such as pernicious anemia. The patient will be pale, and vitiligo. The patients may have depigmented skin, and Addison's disease, where the patients may have postural hypotension and there's a skin pigmentations, especially at the skin fold. We have come to the end of the abdominal and thyroid examinations. We have covered the sequential steps of each exam, and I have listed the important clinical signs to look for and the differential diagnosis for each system examinations. If you have questions and answers, please leave in comment sections, and I'll be happy to see you again in the next lecture. Have a good day. Bye bye.